Hi guys, and welcome to yet another episode of Radiology 365, where we try to cover core radiology from cover to cover. Now we are moving on to another topic, that's pulmonary infection. And today we're going to be talking about the radiographic patterns of pulmonary infection as well as the complications of pulmonary infections. So pneumonia can be classified clinically into community-acquired pneumonia, hospital-acquired pneumonia, healthcare-associated pneumonia, ventilator-associated pneumonia, or even pneumonia in the immunocompromised patient. Strep pneumonia is the most common cause of community-acquired pneumonia. Atypical pneumonia, including mycoplasma, viral, and chlamydia, typically infects young and otherwise healthy patients. Mycoplasma has a varied appearance and it can produce consolidation, it can cause areas of ground glass attenuation, centrilobular nodules, and even tree-in-bud nodules. Legionella is most common among elderly smokers, and infections caused by Legionella tend to be quite severe. Infections by Klebsiella and other gram-negatives occur among alcoholics and aspirators, and it classically leads to voluminous inflammatory exudates that causes the bulging fissure sign. We'll come across that later on. Hospital-acquired pneumonia, as the name implies, occurs in hospitalized patients, and it's due to aspiration of colonized secretions. Hospital-acquired pneumonia is caused by a wide variety of organisms, but the most important pathogens include methicillin-resistant Staph aureus and resistant gram-negatives, including Pseudomonas. You realize most of the organisms in hospital-acquired pneumonia are actually resistant organisms because of the hospital environment. I'm sure we understand that. Then we have ventilator-associated pneumonia, which is caused by infectious agents that are really not present at the time that mechanical ventilation is started. But if the person is on the ventilator for a very long time, you have accumulation of secretions and accumulation of these organisms. Most of the infections are polymicrobial, and they primarily involve gram-negative rods such as Pseudomonas and Acinetobacter. Pneumonia in the immunocompromised patient includes all of the above pathogens, but opportunistic infections including pneumocystis, fungi such as Aspergillus, and some viruses like CMV are all causative organisms, and they can be seen in immunocompromised patients. That's why they are opportunistic. Now to the radiographic patterns of lung infection. We'll first start off with lobar pneumonia. Lobar pneumonia is basically consolidation of a single lobe, hence the name lobar pneumonia. So you could have the right upper lobe having a disease, the right lower lobe, right middle lobe, and so on and so forth. It's usually of bacterial origin, and it's the most common presentation of community acquired pneumonia. Now, when you have consolidation of the lobe, but the bronchi are patent, you have these lucent lines running through the consolidated bronchus, giving the appearance of what we call air bronchograms. So in this plain frontal radiograph, it shows right middle lobe consolidation, and I know it's a right middle lobe because I can see the minor fissure here separating the area of consolidation from the upper lobe. I can also see that the right heart border is silhouetted by this opacity, hence telling me that this is a middle lobe lesion because the right middle lobe abuts the right heart border, hence the silhouette sign seen here. Then we can also see these lucencies within the consolidation signifying air bronchograms. So this was a case of right middle lobar pneumonia. In this sagittal CT scan of the chest, we are in the left hemithorax. It shows a solid appearing left upper lobe without collapse. There's no volume loss, and there are certain bronchi within this consolidation that are patent, showing as air bronchograms. This lung is so dense that it has the appearance of the liver, what would so call hepatization. Then another pattern of lung infection is bronchopneumonia. Unlike lobar pneumonia, bronchopneumonia is patchy peribronchial consolidation, and it usually involves several lobes, not confined to only a single lobe. This is also caused by bacterial, viral, and aspiration pneumonias. So in this frontal chest radiograph, we see bilateral ill-defined patchy opacities of right perihilar and central predominance. So we see this opacity here, we see some opacity here, there's another one at the lower zone here, and in the coronal CT scan we see bilateral patchy bronchocentric consolidation with ground glass halos. You see this opacity here, you see this opacity here, there's another perihilar one here, another one in the right here, here, and here. We see how widespread it is, not necessarily conforming to a single lobe. This is a presentation of bronchopneumonia. Then the next pattern we'll talk about is interstitial pneumonia. Now, interstitial pneumonia is actually a misnomer because it's not only the interstitium that is involved. By and large, even the alveolar spaces also are affected. There's also the point that pneumonia is of infectious origin. However, interstitial pneumonia is not only infectious in origin. There can be other causes like autoimmune conditions, some pneumoconiosis or silicosis. Of course, some infections can also cause an interstitial pattern of inflammatory changes in the lungs. Some of the infectious causes, since we are talking about lung infections, include atypical infections like mycoplasma, chlamydia, viral or pneumocystis pneumonia. Some of the things that we may see include ground glass opacities, fibrotic changes like reticular opacities, or honeycombing in the late stages. So in this axial CT, there are subpleural fine interstitial thickening and ground glass opacities, and it was a case of non-specific interstitial pneumonia. You notice how most of the opacities are reticular and not necessarily opacifying the alveolar spaces. Then the other pattern we'll talk about is round pneumonia. It's an infectious mass-like opacity. It's usually seen in children, and this occurs because the pores of corn are incompletely formed in children. If you look at this schematic diagram here, this represents an alveolus, and this is also another alveolar sac. And in the adults, we have certain communications between the alveolar sacs called the pores of corn. There are also some communications between alveolar sacs and terminal bronchioles called the channels of Lambert, and bronchial to bronchial communication called channels of Martin. But what we are interested in this case are the pores of corn, which are poorly developed in children. In this situation, when one of the alveolar sacs gets infected, the infection is limited to that particular alveolar sac and it can't track into other alveolar sacs. However, in adults who have more completely formed pores of corn, infections within one alveolar sac can track into other alveoli, and hence you can have infections tracking through the entire lobe, causing lobar pneumonia, as we have seen previously. But in children, because of the incompletely formed pores of corn, the infections are usually confined, leading to mass-like rounded opacities in the lungs. Strep pneumonia is the most common culprit. So in this frontal chest radiograph, we see a rounded consolidation in the right middle zone without collapse or effusion. The lungs were otherwise clear. The opacity completely resolved after treatment with antibiotics, consistent with pneumonia. Now we move on to the complications of pneumonia. The first we'll talk about is pulmonary abscess. Pulmonary abscess is necrosis of lung parenchyma. The main culprits include Staph aureus, Pseudomonas, or anaerobes, and often you would see an air fluid level present in the lungs. So in this chest radiograph, we see a cavitating lesion in the left lung apex here. We can see it's mainly opaque, but there is this air fluid level here. Someone told me God didn't create straight lines in the human body. So anytime you see a straight line in the human body, you should have second thoughts. So there is this air fluid level here, indicating a cavitating lesion in the apex of the lung. And this is a CT scan, axial CT scan of the same patient, and it showed a large cavitating cystic mass with air fluid level in the upper lobe, left upper lobe, surrounded by some consolidated lung parenchyma. The mass also showed enhancing lobular contours consistent with a lung abscess. The next complication we'll talk about is an empyema, and an empyema is basically an infection within the pleural space or pus within the pleural space. This fluid conforms to the shape of the pleural space, and on imaging we would see what we call the split pleural sign. That is where you have the visceral pleura and the parietal pleura seen separate from each other and seem to be enhancing on a contrast enhanced study, just like in this coned in axial CT scan of the right hemithorax that we are looking at here, showing the split pleural sign. There's enhancement of the thickened visceral pleura and the parietal pleura, which encase a pleural fluid collection here. The split pleural sign is seen in the majority of exudative effusions, although it's not specific. Similar findings can be seen in malignant effusion, mesothelioma, fibrothorax, and even after talc pleurodasis. Then a step further from empyema is empyema necessitans. It's extension of the empyema to involve the chest wall, and it's mostly secondary to TB. There are some other causative organisms that include actinomyces. So in this axial CT scan of the chest, it shows left-sided pleural thickening and a small pleural collection with large multiloculated thick-walled abscess on the posterior aspect of the left chest wall. So you can see there's a collection here in the posterior chest wall. Seems to be an extension of the collection that's in the pleural space here, and this is empyema necessitans. Then we'll talk about pneumatoceles, which we have seen in previous discussions. It's a thin-walled gas-filled cyst. It may be post-traumatic or as a sequelae of pneumonia. Staph aureus or pneumocystis are the major causative organisms in this case, that is if it's post-pneumonic. So in this frontal radiograph of a newborn, we see bibasal thin-walled cystic lesion. This actually developed 2 months after an initial presentation of bibasal consolidation, and this is consistent with post-pneumonic pneumatoceles. The final complication of a pneumonia we'll talk about is bronchopleural fistula. That is an abnormal communication between the airway and the pleural space. It's caused by the rupture of the visceral pleura, and mostly surgery is the cause, but there can be other causes like abscess, empyema, or even trauma. So on imaging, it's seen as new or increasing gas in the pleural space. It can't be associated with pleural effusion. It's actually mostly associated with pleural effusion. So you would see gas within some effusion on imaging. Sometimes you may be able to see a clear communication between the bronchi and the pleural space. Sometimes you may not be able to see it. In this axial CT scan of the chest, there are areas of direct bronchopleural communication. Seen here, you can see this bronchus is directly communicating with the pleural cavity associated with hydropneumothorax. There's an air fluid level. You can see this air fluid level in this area. So this was actually in the pleural space. The pleural effusion was here, and then there's some air accumulating here as well, and this air is directly communicating with the left bronchus. This occurred as a sequelae of pulmonary tuberculosis. And on that note of tuberculosis, our next discussion is definitely going to be on tuberculosis. Thank you very much for your attention. I hope this was helpful. If you did find it helpful, kindly leave a comment, like this video, and share to someone who you think would appreciate it. See you in the next one.